Well, thank you very much for the opportunity here to listen to these very nice presentations, and I want to congratulate both presenters for their very useful contributions in this field. I would like to make some comments just as opening maybe remarks for further thought. And going first to Miguel's presentation, I was trying to think of how to summarize what he has been presenting, and I thought of creating this little table over there. So it seems to me that more generally, Miguel was trying to say that it is very important to pay attention to the possible differences that a randomized study and an observational study may have in their standard way of thinking about their estimans. Usually people are thinking of the estimand as the ITT, the intention to treat for a randomized study, and as the per protocol for the observational study, or the as treated. And I think that's a very important point. He also made another point, which is that if you think now about the two studies, randomized and observational, but more generally I would say any two studies that have the same estimand, and let's say that they have the same complications, such as selection to treatment at a later time of the follow-up, then they should have the same analysis. So this, in some general way, is useful to think about, but I was trying to also think of what it means maybe a little bit more generally. So I think that the assumption is here that the analysis of a study is a function of the estimand, and i.e. what you want to estimate, and also of the complications that arise in the study, so that if these two are the same across studies, then we should have the same analysis. And while I find this useful, I think that there are a couple of points that we have to think in addition to that. First of all, one thing that may still be different between the two studies, or any other two studies, may be that the mechanism that we understand that addresses the complications can be different. So, for example, suppose that in the randomized study there are variations of the treatment taken after the beginning, but that we understand quite well how these deviations from protocol occurred, because we can talk very easily to the physicians, and they can actually, let's say, have even a model for how they recommended these deviations. Then this model would be like the propensity score model for the deviations, and suppose that we have a very good belief about such a model. Whereas suppose that in an observational study we still assume ignorability, or in layman's terms, that we have all the confounders, but we don't really know what the model is for either the propensity score or for the outcomes. It seems then that in the study where you have more belief about the model for the propensity score, you would like the analysis to be centered around that belief, more so than in the other study where you don't have such a belief about such a model. And doubly robust estimators, for example, try to do that, but even among those, it is still a question of how to concentrate in maybe one or the other of the models, depending on what you believe more. The second point I wanted to make is that also the data may be different. And of course, the data are always different between the two studies, but they can be so different as to suggest actually different analysis. For example, if in a randomized study, the deviations from protocol are so little that by ignoring them, you actually are better off for estimating the per protocol analysis, then that would be a better approximation when you use the analysis just that ignores the protocol deviations. Whereas if in a study, like in an observational study, the protocol deviations are quite high, then obviously you cannot ignore that, and you would have to use an analysis that tailors that. And in regards to Ellie's presentation, I have less to say. I would be very interested. So Ellie basically said that there are ways of trying to generalize from the randomized study to the observational target population, and I think that the covariates, the propensity score, and the extrapolation are useful and very important. I'm thinking, though, that in relation to the presentation by Miguel, when there are measurements after the baseline randomization, post-treatment confounders, it's not clear to me what would be generalizable or what we would like to assume that is generalizable from the randomized study to the observational study. And I know there is work on that, but I think it's something to think about. Thank you very much.